Well, we're here to talk about an issue that's very near and dear to my heart, which is the fact that in the U.S., so often how long you live is determined by where you're from. I've written about this topic in Baltimore, but it's also true of other cities. There's a 20-year life expectancy gap between some of the poorest and richest neighborhoods in many cities around the country. I don't know if any of you looked at the upshot on the New York Times. You can plug in your zip code and see, how much a child is predicted to earn in adulthood based on where they're from. So this is really an issue of national importance, and I'm here to talk with some people about how we can go about fixing it. And Elaine, I wanted to start with you because you're in a very interesting situation. You are the CEO of Martin Luther King Hospital, and it used to have a very awful, unpleasant name, which is Killer King. Talk a little bit about how it developed that moniker and what you're doing to kind of turn things around there, and what are some of the improvements that have been made with the new version of Martin Luther King Hospital?
Sure, thank you. South LA, where my hospital is located, is representative of some of the worst health disparities in our country. It's a community of over 1 million people, largely minority, some huge health disparities, and a deficit of 1,200 physicians. It's the location where the Watts riots erupted in 1965 to protest neglect and injustice. And the public hospital that came out of those riots closed in 2007 after struggling for many years with quality and patient safety problems. We have opened a private community hospital in the same location as a result of a public-private partnership. Funding is offered by the public side, and management and accountability for quality comes from the private side. As a result of that, 3 years in, we're building a culture of innovation, of excellence. We are recruiting top talent to our hospital. We've raised over $50 million in private funds. And just a couple of examples of what we've been able to achieve. This hospital, 3 years in, was certified as HIMSS Level 7. That's the highest level of use of information technology for patient care in a hospital, only achieved by 6.5% of the country's hospitals. Despite the fact that we see 100,000 patients a year in a 29-bed emergency department, we're rated in the top 10% for patient experience. So what we're doing is a little unconventional. We're trying to bring first-class healthcare to a low-income, under-resourced community using some innovative models.
And I wanted, just in case people aren't familiar with South LA, one statistic that you told me backstage was that you do several amputations a week, not from war injuries, but from diabetes.
That's right.
Yeah.
From diabetes, which is epidemic in communities like South LA.
And what percentage of your population is on Medicaid?
About 70% of our population is on Medicaid. So what we're doing is unconventional because we all know that there are huge disparities in reimbursement between Medicaid, Medicare, and commercial insurance. And that's one of the reasons we have such a huge deficit of physicians there and the epidemic of chronic illnesses.
So what you're actually talking about is a shortage of specialists in some of these areas because they actually can't make enough if they won't make as much if they move into these areas.
That's
is that
correct.
Right? Okay.
We work closely with community clinics, which do a great job of providing primary care and taking care of moms and kids, but we're taking care of very complex adults, and there's just a huge need for more specialists to help take care of that population.
And you bring in, that's where the private funding comes in.
Absolutely.
To help reimburse
Helping with that. Mm-hmm.
Wow. So let's talk about, once the doctors are actually in place, this is a question for everyone. Something that I noticed in some of these low-income communities is that there's not a lot of health literacy, that it's difficult for people to find accurate information about health, that it's sort of confusing. They hear different things from different doctors. What can we do to actually improve health literacy in some of these communities?
So, 36% of Americans are thought to be not at a health literacy standard that they could really make the right decisions about their own health. But if you peel back that onion, it goes really to the issue you brought up earlier, and I think understanding the national picture is about understanding the local picture. Mm-hmm. Like politics, all health is local. Understanding what's happening in each community. And in fact, we published data looking at this earlier that for every $1,000 in difference in median outcome within African American communities is linked to a 5-year difference in life expectancy.
Wow.
right? So what you're looking at there is a compound issue that actually ultimately lead to the most defining factor. It's just how long you live.
Mm-hmm.
And so understanding what's happening in local communities when it comes to the issue of trust, engagement, understanding how to deal with their own healthcare, which you explored well in your article, is really about understanding what's happening in a local community. And our thought pattern is really, local interventions, locally measured, national in impact. So understanding what's happening locally is really about understanding the national picture.
So what would some of those local interventions be?
So, for instance, there's this amazing project that we just announced that we're supporting today in Detroit, the Detroit Food Lab. And what they're doing there is linking entrepreneurial spirits to the concept of healthy food. Mm-hmm. And so understanding that if you give people a job, education, a job, and the kind of opportunities to lift themselves up, they are then in a better place to make some of those choices you speak of. And I think of my own life story. I think of the fact that for our family, education was a ticket that keeps on giving. Mm-hmm. And so understanding how these educational and economic opportunities create both a health literate community, but also a health literate family is particularly important.
Right. And I wanted to talk a little bit about this issue of something else that I noticed when I was in Baltimore is that a lot of people don't trust the doctors that they do meet because they've been mistreated so many times. They are sort of reluctant to even go get health care, even when they need it. And I was wondering if we could talk a little bit about how physicians are trained or whether there's anything we can do to improve actually the communication between the doctor and the patient. That's a question for anyone.
Well, one thing I would say is that it helps when doctors reflect the community that they're treating. Mm-hmm. And we have a very diverse physician and clinical workforce. And I think we're all challenged to bring more minorities into the physician pipeline. The other thing we do is we use health navigators who are from the community, who understand people in the community and can be that bridge between the community and the health system and help build the trust.
Yeah, and this is, what Saha published back in 1999 in JAMA, showing that in African American populations, their perceived quality and to some degree their actual quality and Hispanic populations was improved based on physician concordance. So some of this is the data that is scientifically proven. And truth be told, in South Central and other places where you have Drew Medical Center, you have Meharry in Tennessee, you have a lot of places that are producing minority physicians that serve minority communities. And so understanding the importance of those institutions and supporting those institutions, I think, is integral to improving that local community health that we talked about.
Right. And Jeff, I liked what you were saying backstage about physicians being trained more like a priesthood. What does that mean, and how can we go about changing that?
I just want to mention real quickly a study that sort of brings this to a head. They videoed a vignette of 4 patients describing chest pain. So an African-American male, African-American woman, and Caucasian woman, and they gave the exact same description of their chest pain. And even the intonations were very similar. And they showed it to physicians at a national conference. And they asked them, what would you do in response to this? Would you do further cardiac testing? And what we would all hope and what we'd expect in a scientific discipline is the answer would be exactly the same, regardless of whether it was a male or a woman or a man or African-American or Caucasian. And it turned out to follow, the white male was most likely to get the cardiac stress test, then the African-American male, then the white woman, the African-American woman, and the least likely. So that's sort of a staggering thing. Like, that should make you really uncomfortable because we hold medicine up to be a scientific, rigorous discipline. And what you find out is that we're just a reflection of the rest of society. All of the biases, all of the flaws, and all the imperfections that we all have are true in healthcare as well, and in how we train in a culture of physicians. So if you look at the way med schools are run and the tradition, it's much more like a priesthood. If you've ever watched residents and med students follow the physicians around in the wards, literally they're in a line from the most senior to the next, to the next, to the next, the next junior resident to the med student. They even have coats of different lengths that are reflective of where they are in the training. And what the both implicit and explicit direction to the physicians in training is fealty to authority. So it's not a modern, liberal, critical education tradition where you question authority and you question what you're taught. And there's a kind of an unruly process of critical thinking, it's a much older tradition, much more of a sort of Greek tradition of remembering, of memorization, and of following your leaders and doing what they tell you to do. And there are many ways in which that's worked. You want to watch a physician do a surgery and then try and do it exactly how they did it. But for other problems that are much more complicated, that lack of critical thinking is going to cause a problem.
Wow. Well, and we just heard from SEMA, so I wanted to give you guys a chance to respond and possibly get yourselves in trouble with your PR people. What do you think about some of the changes this administration is making to healthcare, both changes to the Affordable Care Act, changes to Medicaid? I know this isn't affecting California as much, but in some places they're talking about work requirements for Medicaid and for food stamps. How will this affect some of these populations that are most vulnerable?
Well, there's no question that some of the changes that they're making are going to mean that less people will have health insurance coverage. Work requirements are regressive. Changes to some of the benefit activity, particularly around immigrants, are regressive. And I think that's the biggest issue. We need to have a system with everyone in and nobody out. Healthcare is not discretionary. And I think until our nation gets to that point that we absolutely recognize that, we're going to have continued problems.
Yeah. What should be happening instead with Medicaid or the Affordable Care Act?
Well, we need to move from a model where they think of Medicaid as something which is a backstop to what it was intended to be under the Affordable Care Act, coverage for everyone who couldn't get coverage through their employer or another system, or could get it in a more affordable way. The Affordable Care Act was designed to do that. And again, many of the things that they've done have really undermined that effort. Now, that doesn't mean that, we clearly should not work with the administration, obviously, to try to improve some of the healthcare coverage activities that they do. They certainly have been very much interested in trying to reduce cost of prescription drugs, been all over the opioid epidemic as a big issue, which, by the way, we come back to that, but that is a significant, the opioid epidemic is a significant issue in that it's been the major cause of reduction in life expectancy for the last 3 years.
Right.
So we do need to deal with that. But I think if you don't have a system with everyone in and everyone having access to care, how can you possibly change those numbers?
And since we're at a conference on health equity, I would say that until we have more parity in reimbursement, we will continue to have the kind of disparities that we see in communities like South LA. The average American community has 10 times as many physicians as practice in South LA, and that's related to reimbursement.
And you mean reimbursement between Medicare and Medicaid?
Medicaid, Medicare, and commercial insurance.
Right.
So I would like to see more parity and more equity there so that we can translate that into health equity.
So speaking of hospitals, Jeff, I wanted to talk with you a little bit about how we can balance the kind of quality that you're getting at hospitals, which is often very high, with the price, which is also unfortunately often very high. What are some interesting things that, you mentioned that a lot of states might be doing more rate setting in the future. Why do you think that, and why might that be?
So Seema talked about earlier, we have the most expensive healthcare system in the world, and we also don't cover everyone. So we're spending a lot of money, and by many measures, we have poorer quality healthcare than other countries. And when you pull off the lid of those other systems, many of those other countries have a national fee schedule. So if you look at cost in healthcare, is a mix of price and utilization. Our prices are some of the highest in the world, and our utilization is out of whack. In some cases it's lower, some cases it's higher, but it's often irrational. It doesn't necessarily follow need. So if you go back to price, there's a real irony in healthcare that's challenging. If one hospital in Washington, D.C. does all the open heart surgeries, you want to go to that hospital, and the quality of the open heart surgery will be much higher. If instead you take that same market share and you divide it across 4 or 5 hospitals, the quality in each of those hospitals, because they're not doing as many, will be lower. But if you're an insurer and you're negotiating for price, you actually want to negotiate with 4 different hospitals. If you allow all the open heart surgeries to be done by one hospital, then they can demand a much higher price. So in healthcare, monopoly equals higher prices, but often higher quality. So we actually have a whole history of how to deal with this. This isn't a new problem. You know, you can't have 5 water lines running to your house. You can't have 4 cable TV providers running to your house. So we have a whole history of how to handle natural monopolies that occur. And in healthcare, we've got a tension between allowing for aggregation of cases and one entity getting really good at that, and the inability then to let price float within the system. So we haven't even talked about that. And that's probably one of the biggest drivers right now of increases in healthcare spending is the consolidation of the hospital industry and the inability of the private sector to even begin to address that.
I'm going to take questions from the audience in a minute, but first I want to talk about food, which is a major social determinant of health. And I actually have seen mixed evidence on this. You know, there's this concept of food deserts, which are certainly a thing, and there's been some studies kind of suggesting that maybe they aren't really a huge driver of obesity in some of these areas. You know, at the same time, if you drive around, you know, South Los Angeles, you see a lot of fast food places. You see unhealthy restaurants everywhere. And I think they actually tried a fast food ban there not long ago, and it had kind of some mixed results. So I was wondering whether you guys have seen anything interesting in the food space, either reining in fast food or bringing in healthier food into some of these areas.
Well, one of the things that we're doing in our hospital is we're modeling healthy eating for the community. So we're one of the few places in the community that isn't a fast food restaurant, and where people can come and get fresh fruit and vegetables, whole grains, prepared in a way that is culturally aligned with the community. We've also added food as part of how we treat illnesses. So we know that, for example, people who have congestive heart failure need to be on a special diet. We've started helping provide the food for those folks so that they have access to what they need to manage their conditions.
Oh, wow. So you actually send it to their house? Or
we actually have a program where our doctors write a prescription for food that is then fulfilled by our food services.
Wow.
You know, food is part of a broader problem. So we have a pretty big partnership with Meals on Wheels where we're trying to get into people's homes to make sure that they have access to the right food. But going back to the statistic that you articulated earlier in terms of looking at zip codes and how that has predetermined even life expectancy and opportunity in children. I look at my own community, and when I drive through where I grew up, I see liquor store, Chinese food, fast food place, and I see that repeated almost in every sequence in a DNA structure almost.
Yeah.
And what that shows to me is not so much that the food is a challenge, but that the opportunities we have where I come from and the opportunities that my folks in my community have are limited, and that's the food is kind of the tip of the iceberg beyond all of that. We have to make sure that we get into communities and deal with the food issue, but we have to dig deeper to the root causes and understanding the root cause of all of these problems. We talked a lot about what's happening. I'm a interventional cardiologist by training, and I'll tell you that what I see is the tip of the iceberg. What we see when we see a patient for an hour or 2, 3 hours in a year is not what they spend the 8,000 hours they spend out in the community. And so understanding, getting to the root causes of these issues, I think, is a bigger issue. So I was happy to hear the administrator mention the concept of social determinants of health. And we should repeat that conversation today when we talk about these challenges.
Absolutely. Does anyone have questions for the panel? We've got mic runners coming around. Any questions yet? I can't really see.
Sure. Oh. Hi, Sydney Etheridge with Planned Parenthood Federation of America. And you mentioned earlier that we're seeing women are having kind of the furthest reach when it comes to equitable access to healthcare. And I'd be interested in wondering what your organizations are doing to take into consideration the unique needs of women, particularly outside of the pregnancy space, knowing that we'll talk about that later, but women spend majority of their life not pregnant or not trying to get pregnant.
Well, you know, certainly we've been working very hard to make sure people understand that Planned Parenthood clinics provide a whole range of healthcare services for both men and women, and that they're an essential component of the healthcare community. And if they went away tomorrow, there is not the capacity to replace you. So it's, you know, it would cause devastation in many of those communities, as well as the economic, not just the health hardship, but they're also an economic engine for those communities.
Yeah, the infant mortality rate in our country is an ongoing challenge that we need to be focused on. particularly in African American communities, we continue to see widening of that infant mortality gap since the 1980s even till now. And that deals with the concept of preconception care even before you get pregnant. And the driver of very low birth weight and low birth weight, which in Baltimore and DC where we're at, you see some of the more challenging statistics. So what I say, I think it is somewhat repetitive, is we have to understand the challenges that women are facing even before they get into the doctor's office, and how we can make sure that we're providing the right care.
Absolutely.
Hi, my name is Melissa Jost. I am our Director for Clinical Informatics at University of California, Davis Health. And my question is for Elaine. At MLK Hospital, congratulations on achieving HIMSS Level 7. I know that's a really big accomplishment. But I was wondering what sort of technologies you're using to improve patient access and specifically access to that specialty care.
It's a great question, because one of the things that we did when we started our hospitals, we made sure that the entire hospital was wired for telemedicine. And that's a huge way to improve access to specialty care. When we opened, we were unable to find some of the specialists that we needed in the local community, and we relied on telemedicine to provide access. The other way telemedicine works is on the outpatient side as well, to provide access to specialty care, and then also to connect the different parts of the healthcare system so that patient information travels with the patient and doctors know what's happening with their patient regardless of where they're seeking care.
This woman has her hand up in the middle.
Ellen Milheiser, Synopsis Newsletter. You heard Seema Verma talk about using increased access to electronic health records as a major way of the administration improving patients' access to information. How does that equate to a lower socioeconomic neighborhood where they might not even know how to access this or have the technology to do so?
Well, it turns out that most low-income communities generally have access to the cell phones and the technology. Now, having said that, we still have not only food deserts, but we have broadband deserts what we have to address. But for the majority of people, I think she's right that improving access to the health system and getting your record in is important, and making sure that record is transportable so that no matter where you are on the planet, you can access your health record just like you can your ATM machine. I do think that there needs to be a coordinated effort focused on low-income communities specifically to make sure that Wi-Fi and high-speed Wi-Fi is available so you can get your record, and people being, of course, trained and tooled to how to do that. Now, some of that's generational. All of our kids are much more facile with their toys than we are, but it's also economical. And as the price of those tools, cell phones and technology comes down, more and more people will use it.
I think technology is also a tool. And we have to not get enamored by the tools and forget about the people bit that we're trying to reach behind the tools. EHRs, AI, all of these various kinds of tools that are now coming into our sphere, we have to understand how to deploy them, not to the worried well, but to those who are most in need. And so understanding how it gets to my community and some similar kinds of places is, I think, where we really need to focus effort, not just on the development of the tools.
They're introducing a new kind of error as well. In Camden, we were seeing high rates of incorrect diagnosis for complex patients. And with the electronic health record, your incorrect diagnoses follow you everywhere. And both incorrect medical diagnoses, and no one cleans up the problem list. So you just, every admission that you go in and out, you just keep getting more and more diagnoses attached to you. So one of the most common incorrect diagnoses that we saw was bipolar disorder, so which results in incorrect medication. So there were patients that really had early life trauma with depression, and the irritability that they would express if they yelled at someone in the healthcare setting, suddenly that got translated into bipolar disorder with the wrong medicine, and that sort of following them around. So I'm really worried about the implications of these technologies, and we don't think enough about, technology just accelerates bad care if we're not thoughtful about the kind of care we're delivering.
Unfortunately, that's our time, but thank you so much, you guys, for taking on this huge issue, and thank you all for being here.